Welcome, everybody. This is bringing up the rear in the third lecture of the series. I've really enjoyed actually joining these meetings. It's been really very knowledgeable and interesting to actually communicate with colleagues. So the remit for this afternoon is just to spend the next 30 to 45 minutes to discuss endoscopic submucosal dissection of colorectal lesions. Which I think is the bulk of our work here at King's in terms of ESD. And you know, this audience is well known, knows as well that actually colorectal cancer is extremely common, and actually 10% of all annually diagnosed cancers and cancer deaths worldwide. But now we have national screening programs in place across Europe and the US that has increased the stage migration of these cancers and therefore improve survival. Therefore, we're seeing more lesions that are suitable. An endoscopic submucosal dissection is now really, I think, accepted in many centers worldwide. And I just want to take you through, in the initial sort of 3 or 4 minutes of the lecture, exactly, you know, what the sort of history of this acceptance worldwide has been. I think in the UK, we have NICE, which is the National Institute of Health and Care Excellence. And NICE usually produces guidance for all procedures, and in particular new interventional endoscopy procedures. And the last guidance with not much updates was back in 2010 for ESD of lower GI lesions. But really what they recommended, and I think this is still actually occurring now, is that this should be limited to expert centers with certainly regular audit and further research regarding the outcomes of ESD to be carefully monitored, and certainly we are no further with that. Many of you are aware, certainly in Europe, this particular publication from the ESGE in 2015, and there were certain guidelines that were established, which many people in Europe and us follow. I just want to take you through a couple of those things in terms of history. So here it really says that ESD, you know, should be certainly considered for patients that have lesions both in the colon and the rectum with high suspicion of limited submucosal invasion. And then it goes on to describe the criteria for that in terms of either having, you know, elements of depressed morphology or irregular or non-granular surface pattern, and also lesions that can't potentially be treated en bloc. But very difficult, I think, to identify, you know, exactly the lesions which have the high suspicion of limited submucosal invasion. So diagnosis is very important. Also went on to recommend that, you know, further recommendations as to after you have the ESD, you know, you should recommend surgery if there are high-risk features, and high-risk features on ESD in the colon and rectum would be those patients that have either vascular invasion, if they have deeper than SM1 infiltration for the cancer, if there are positive margins, or if there is a poorly differentiated tumor that is actually diagnosed. So this requires discussion with patients regarding lymph node harvest and further laparoscopic colorectal surgery. And if you look at this in a bit more detail in terms of recommendations for further surgery or not, on the left-hand screen here, you can see that if you've got vertical margins that are actually clear, and there is an R0 resection, and if it's low risk with no very small degree of submucosal invasion, or if there is no lymphatic or vascular invasion, and there is well differentiation, then endoscopic resection is termed curative. And if there is indeed, you know, poor differentiation or lymphatic or vascular invasion, then we should discuss with patients regarding lymph node harvest or not. And then indeed, obviously, if we have, you know, vertical margin positivity and it's an R1 resection, then we should be recommending these patients to have surgery. The American, across the pond in the US, the American societies have also published several guidance, and this was in particular expert review last year, you know, from the AGA, and really, I think for the US, it was once again similar to what we are saying in the UK about a decade ago, which was essentially that this should be referred to high volume centers and consider ESD for high risk lesions as we've described. But I think, the sort of mecca of ESD has been in the Far East and in Japan, and the Japanese have always guided us regarding, what we should do in terms of indications. And the Japanese Gastroenterology Society guidance actually recently updated and published just in 2020. And you should have access to all these references, by the way, to look at afterwards, which we can send you. It really looks to see what are the indications and what we should do in terms of further treatment. So let's just go through that in a bit more detail. So in terms of lesions which should be resected en bloc, we should resect really lesions with the JGES states is patients where snare EMR is difficult to resect en bloc. So they would resect patients really above 20 millimeters that they can't resect en bloc by snare, or patients that have LSTNG, or lesions showing a 5I pit pattern, or those with early submucosal invasion, are all lesions that are big nodular components that have a higher risk of having underlying cancer. Obviously, there are also many patients that may have fibrosis, either natural fibrosis with LSTNG, or fibrosis with previous biopsy and treatment, or patients that have fibrosis related to chronic inflammation such as ulcerative colitis. So those really are the indications for en bloc resection from the Japanese Society. But their recommendations are quite clear that we should be using in their practice magnification endoscopy to look at pit pattern and also spectral imaging in terms of vascular pattern, no biopsy prior to resection, and we need to diagnose the depth of invasion. They sort of advocate that there is a 90% accuracy for magnification for flat lesions, and less so for more nodular component. But the non-lifting sign is not useful, and we obviously found that in our practice because it's a very, very poor diagnostic sensitivity for SM deep invasion, because you don't really know whether it's just fibrosis or whether it's indeed submucosal invasive cancer. So just looking at this in a bit more detail here, similar to what we saw with the ESG, negative vertical margins itself, if they are low risk features of all the features that we discussed before, in addition to low degree of tumor budding, then these are endoscopically resectable. But if you've got depth of invasion greater than 1,000 microns, or if you've got poor differentiation or signet ring or vascular invasion or tumor budding, then we should think about lymph node harvest for these patients. And obviously patients with a vertical margin that's positive, and we can probably discuss this in the discussion after the lecture about what a vertical margin actually means, and I'll be interested to get people's views on this, that they should consider lymph node harvest. So actually, in terms of SM invasion, one of the difficulties is what is the risk that you tell your patients that is their risk of lymph node metastasis if they have submucosal invasive cancer. And this is actually a paper that's over 16 years old, but really essentially one of the take-home points from this paper is that we mustn't only go on SM invasion as in depth as the only factor, because there are many patients that have SM invasion that are greater than 1,000 microns with no other high-risk features that have a very low risk of lymph node metastasis. And in this particular series, it was 1.3% risk of lymph node metastasis. So this really requires a discussion with patients and discussing their risk and benefit of further lymph node harvest. So we shouldn't just go by the SM invasion, we should take everything else into account. But before looking at the lesions and seeing indications of ESD and what we should be doing from the different societies around the world and what we're doing in our practice, we've got to get the diagnosis right. And to get the diagnosis right, we have to get the basics right. And this involves thorough examination, not only on white light endoscopy, but using appropriate insufflation and deflation and change of position and detecting that faint redness in order to identify the flat lesions that potentially could be missed, and also to understand the classification of endoscopic diagnosis so that you can actually see, because you really only see what you know. So we must have a thorough understanding of endoscopic diagnosis, and that's what I'd like to focus on. I just want to take you through a couple of patients that come across in my practice, which alerted me to look at this in a bit more detail in terms of careful observation. And here's a gentleman who was referred actually for rectal ESD patient with colitis, and that was well controlled in terms of their UC. This is a lesion which is LSTG homogeneous type, very small nodules in the rectum, extremely scarred in the rectum, and actually endoscopically benign, tubular adenoma, which has got intense fibrosis seen on the high frequency mini probe ultrasound with no space between the mucosa and the submucosa itself. And we did an ESD of this patient, and this was a tubular adenoma with low-grade dysplasia that was completely resected, and patient didn't have any recurrence. However, when we did the examination at 12 months, this is what we found in the sigmoid colon. And you can see really that here, I hope this portrays across, very, very slight faint area here, which is slightly redder, with a small difference in the contour itself. And if you deflate the colon and come back, you'll see it much more prominent. And then if you dye spray and use spectral imaging, you can see that there is quite clearly a small lesion, which was resected and was actually an adenocarcinoma with early invasion. So detection of that faint redness was extremely important. Equally, this is another patient. In fact, again, with UC, we've got a lot of patients with UC that we get referred from our tertiary referral practice, who was referred for evaluation of his UC and was discovered to have a 2 centimeter adenoma in the transverse colon. When you look at this image itself, you can see there's some areas here on the anal side that in the transverse colon that are suspicious of having an adenoma, but this could go on a little bit further. If you can see the arrow pointing, spectral imaging doesn't really help, but it does show you that it's potentially a bit more extensive. And you can see on magnification, this is a tubular adenoma, but when you dye spray, you can see it very, very carefully. So careful examination using deflation, insufflation, using spectral imaging, and using chromoendoscopy with detection of faint redness is extremely important. So really, in terms of characterization, in terms of endoscopic diagnosis, to identify those high-risk lesions and to identify the lesions that are suitable for ESD, we must have a thorough understanding of the characterization of colorectal polyps, not only in terms of Paris classification, in terms of morphology, but also pit pattern classification and spectral imaging. And I'm a big advocate of magnification endoscopy, so I'm just going to share with you some of our thoughts about how we would assess patients with colorectal polyps and what is our decision making regarding ESD or not, or indeed EMR. So let me take you through this. So in terms of options for resections, you all know that options for resection can either be piecemeal EMR, or they can be ESD, or indeed full thickness resection or laparoscopic surgery. But one of the difficulties around the world is that often we make decisions based on local expertise as to what's available in that area or in that institution, rather than endoscopic diagnosis. So if you go and see somebody that's more an endoscopic enthusiast, you're more likely to get more endoscopic treatment for EMR if they can't do ESD, or if you go to see a surgical specialty, you're more likely to get more surgical resection rather than endoscopic treatment. But now I think that is improving, because we are indeed referring more patients to the tertiary referral centres based on expertise. So in terms of early colorectal cancer, of course, we need to have a discussion with patients regarding the risk of lymph node metastasis, and also identify those lesions that are technically resectable by ESD for early submucosal invasion, because all societies have essentially said that this is the purest and the best indication for ESD. But also, don't forget that it's important to resect high-risk benign lesions on the chance that we may find incidental cancer, which would be a disaster if we were to do piecemeal resection and therefore not know the depth of invasion and have positive margins. So, if we do suspect invasion, we must provide a single specimen that includes all of the submucosa so that we can evaluate this pathologically as best to our abilities. So here we go. Let's look at endoscopic diagnosis in our path at King's. Let's look at also the indications itself, and also a little bit of discussions about pathology, and then finish on the technical aspects of ESD. So dye spray and magnification endoscopy, this is magnification, up to 80 to 130 times magnification. And quite clearly, you're all very familiar with this, so I'm not going to dwell on this for too long. But essentially, we can dye spray either with chroma endoscopy using indigo carmine, or for the 5I and 5N pit pattern, we also can use crystal violet in order to define those irregular pits and the non-structured pits in much more detail. And equally with vascular pattern, it doesn't matter what type of spectral imaging that you're using, but what's important is to look at the vascular pattern. And this particular vascular pattern is actually the Shoah classification from Professor Kudo's unit, where I trained in 2010. And this is really looking at the vascular pattern either being honeycomb, which is normal, or faint, that's hyperplastic, or you've got network of vessels, that's a tubular adenoma, or dense pattern, which I think is very beautiful, as tubulovillous adenoma, or irregular or sparse pattern that could indicate either early submucosal invasion or high-grade dysplasia, or indeed deep submucosal invasion itself. But there are lots of other spectral imaging classifications, and one of the things that many are using in the United Kingdom is NICE, which is much simpler, but I personally don't feel it's that nice in terms of the detail. So it's divided into type 1, 2, or 3, and either really indicating whether it's adenomatous or hyperplastic, or indeed deep submucosal invasive cancer, but difficulty in the bridge between the two sometimes with this classification. So in our practice, we use a JNET classification, which subdivides the type 2 into type 2A and type 2B, where type 2A is very regular vessels, that's regular caliber and regular distribution, and type 2B are those that are slightly irregular, and then type 3, which is completely obliterated in fairly amorphous areas. So therefore, what we would do is if we see a type 2B lesion, then these lesions must have chromoendoscopy to evaluate further the pit pattern and make a decision whether this is indeed early submucosal invasive cancer or not. But if it's type 2A, then spectral imaging is usually extremely accurate for making a decision regarding endoscopic treatment. And equally, if you've got the actual spectral imaging itself, can be used across all modalities. And here you've got quite a regular vessel pattern that you can see with this lesion itself. And this is quite clearly something that is benign and endoscopically resectable and doesn't have any of the features of having type 2B JNET, and therefore unlikely to have evidence of invasive cancer. So how do we actually assess these polyps in our practice? What we would do is we would obviously look at the morphology initially in terms of Paris classification, and then we'd use magnification endoscopy to look at pit pattern in a bit more detail, and then make a decision regarding treatment. And really, I'm going to be discussing to you as to which patients would be suitable for ESD. So the thing that we need to really look into a bit more detail regarding Paris classification are lesions that are generally referred for ESD, which are lesions that are lateral spreading tumor. This was first described in the mid-90s, and LST, as you know, can be subdivided into granular or non-granular type, and LST granular can also be subdivided into either homogeneous or mixed nodular type. And then you have LSTNG, which is flat type or pseudodepressed type. And what's important about this differentiation is as you go from top left to bottom right, you increase the risk of submucosal invasion. And also what's interesting is as you go from top left to bottom right, you increase the areas of submucosal invasion. So it's more likely to be multifocal here with LSTNG in the pseudodepressed and flat type, and more likely to be unifocal in the lesions that are homogeneous type or LSTG mixed nodular type. So if we've got a lesion that's LSTG homogeneous type, what do? Well, the risk of submucosal invasion in our practice is very low, it's 0.8%. This is the data from Showa University when I was there, from Professor Kudo's unit. And their risk of submucosal invasion is extremely low for LSTG homogeneous type at 0.8%. So many people would argue that if you've got a big LSTG homogeneous type in the right colon, for example, that might be difficult to resect en bloc by ESD, many people might argue that as this has got a very low risk of submucosal invasion, less than 1%, then we can treat these patients with piecemeal EMR, for example, in this large lesion in the ascending colon. However, we need to consider the cost of recurrence, and certainly the cost of recurrence post-EMR needs to be considered for patients. And in our practice, what we do after piecemeal EMR is we would dye spray the scar, and we would very carefully use magnification endoscopy to ensure that there is no residual lesions. And once we feel that there's no residual lesion itself, we would say that's completely resected with magnification. But even despite doing this, what we did is we used endorota, which is actually a small morcellator that many of you may have seen, which is from Interscope. And this actually, we took samples of the edge of the lesion and sampled the circumferential margins. And actually, we found that despite doing what we thought was an excellent job in terms of piecemeal EMR, there was 13% residual adenoma in the sampling of this area. So all those studies that advocate the use of snare tip coagulation and other methods to treat the edges are really doing this. They are reducing that risk of recurrence by treating residual adenoma. And if we look at our lesions of over 600 patients with a mean size of over 5 centimeters, actually doing piecemeal EMR recurrence is high. Recurrence is high, over 14%, and patients require a median of 2 further endoscopic resections to have a completely clear colon, and this means more visits to the hospital and higher cost to the patient and to the institution, with some patients even requiring surgery. And the other issue about endoscopic mucosal resection, piecemeal, is that it requires a long surveillance, and we've shown categorically in the literature that you can get the recurrence even at 36 months, whether the recurrence rate initially might be small, and this could be related to some of the mucosal healing that you see initially after piecemeal resection, which is clear in the first 12 months, and then you have initial submucosal recurrence then breaks through into the mucosa that can happen at 3 to 5 years, and certainly the Japanese have reported that as well. So that's something to consider regarding, making a decision about piecemeal EMR. What about LSTG mixed nodular type? Well, in our practice, 11% risk of submucosal invasion. In the Japanese data, 19% risk of submucosal invasion. So if we have a big nodular component, and even if we think endoscopically this is benign and tubulovillous adenoma, one of the difficulties with magnification endoscopy is that it's not as sensitive for nodular components. So be careful with that. And we need to ensure that we have en bloc resection of LSTG mixed nodular type, because there is a risk of invasive cancer despite benign pit pattern on the nodular component. So our decision making itself, we sometimes in our practice, when we have difficulties on magnification, we may use high frequency mini probe ultrasound through the scopes to ensure that we have a favorable muscularis propria before embarking on a large ESD in the colon for particular, if there are difficulties with magnification diagnosis. And obviously, once you've resected this lesion, then these lesions need to be pinned appropriately and sent to histology for proper evaluation. What about LST non-granular type? In our practice, 18% risk of submucosal invasion. In the Japanese data, up to 41% risk of submucosal invasion. And what's interesting is that these lesions have more scar and more fibrosis because they tend to have more of a desmoplastic reaction. And also these patients have a higher invasion in terms of multifocal invasion. So if you do piecemeal EMR, it would be a disaster because you're likely to have residual disease and positive margins. So they must be treated by ESD en bloc. So just to summarize, guys, what we've said so far, all polyps that we would assess, we would look at morphology like you would, Paris classification, magnification endoscopy for all patients. We've been using that routinely since 2011, looking at pit pattern and vascular pattern, and then make a decision. this 5i pit or this LSTNG, this is en bloc resection for sure. Now, in terms of 5i pit, you can go into much more detail regarding this, and we certainly do because we have an interest in this particular aspect of magnification. So 5i can be subdivided, as you know, into 5i irregular or non-structured, and then the irregular can also be subdivided into low grade or high grade, and that's sometimes academic and very difficult to differentiate. However, you can differentiate this with crystal violet, and this is 5i low grade. That you can see this is actually high-grade dysplasia. When it's slightly abnormal, this is actually when there's irregular margins and there are very narrow pits, this is high grade. And then when there is non-structured, then this is 5N pit. So you can look at that in a bit more detail as well. So this is the three that we just saw. You can see this is low grade, this is high grade, and this is non-structured. So you could say high-grade dysplasia, early submucosal invasion, and deep submucosal invasion. And looking carefully, this gives you a bit more information. So in our practice, we don't always rely on the 5-pit pattern because we're not as good as the Japanese in our evaluation. So we would always do a high-frequency mini-probe ultrasound just to make sure that the MP is favorable, that we haven't got it wrong in terms of the magnification diagnosis before we embark on an ESD in the colon. In particular, obviously in the rectum is less of a problem, and if it's 5N pit, then that is a different lecture altogether, but they need to consider surgery or full thickness resection. So this is just an example. This is a patient that was referred to me, actually is an 82-year-old distal sigmoid on biopsy cancer, previously treated as well, but not fit for major resection, and very difficult to evaluate because they'd had previous resection and previous biopsies. So is it 5N pit? Is it 5i? We thought it was 5i high grade. We felt there was 2C component. The ultrasound showed that this was deep submucosal invasion. You can see the MP is here, it's quite clear. The posterior limit of the submucosa is very sharp and clear, and this is going into the deep submucosa, but is not touching the base of it. So we felt that actually that the MP was favorable, and therefore there was some space. And if you look at this, actually, this is the image on ESD. This is exactly the same spot on where it is on the ultrasound. This is a video image of the actual dissection, but we can get just below it here with the fibrosis and resect this. And this was SM2 invasive disease, which was resected en bloc completely for this patient that was treated endoscopically. So 5i pit, important to evaluate, and we use ultrasound as an adjunct. What about LST mixed nodular type? The summary, these patients need ESD for sure. So if you've got patients with a nodular component, despite you've got JNET type 2B and cancer diagnoses here, we can identify exactly where the cancer is en bloc, and then we can make decisions regarding further treatment. Equally here, if you've got a nodular component, we would just resect it en bloc, irrespective of size, in terms of our lesion size. This is a lesion just of 25 millimeters. What's interesting, I like to show this slide, because if it's in the rectum, we have to be extremely careful. And this is an LSTG mixed nodular type in the rectum. And often when you have patients like this, you get referred them, they will have an MRI, and often the MRI can overstage these tumors because it's very low and the rectum is collapsed and it's not inflated when they have the MRI. So it can overstage them as T2 or T3 being very low. Someone may take a biopsy from here and they may have invasive cancer or may have high-grade dysplasia or suspicion. And then patients often get over-treatment in terms of going down the route of neoadjuvant chemoradiation or major resection such as AP resection because it's been evaluated not as carefully as we would endoscopically. Now, endoscopic evaluation is very important, and resecting these en bloc gives you the opportunity not only to endoscopically cure this patient, but if you have an invasive cancer here, for example, which is 3 or 4 centimeters from the anal verge and from the anus itself here, then there is opportunity for this patient, if they are high risk in terms of features, to go on and have a laparoscopic ultra-low anterior section with primary anastomosis and loop ileostomy, rather than having an AP resection. So you can actually use this to guide your surgical management as well, which is what we do routinely in our practice. And if you've got lesions that are very large that are resected, then you do have problems with stenosis, and I want to talk a little bit about that. And here sometimes we painfully leave just even a small area of normal mucosa, even if we've resected a 15 or a 16 centimeter lesion, just to reduce that risk of stenosis. This is from my mentor, Dr. Haji from Showa University, and actually what they showed that overall in the 822 patients for colorectal ESD, risk of stenosis was extremely low, only 0.5%. But if you've got circumference between 90 and 100 circumference, then that risk is 11%. And if it's 100% circumference, then half their patients actually had stenosis itself, which actually needed either 2 to 3 dilatations in order to improve their symptoms, but they all were managed endoscopically with dilatation. And if we look at the literature regarding this, it's very, very similar. And this was actually a meta-analysis that was looking at this, and they actually only commented on a review of the risk of stenosis, and they just showed that actually 90 to 100% of literature, you've got up to 40% risk, and 100% is 50 to 71%. So less than 90%, you're not going to have a risk of stenosis, very unlikely. Therefore, we painfully resect these lesions and therefore try and leave a normal layer of mucosa if we can. What about lesions that are scarred? Of course, these patients are very difficult to treat by EMR, so we would treat those by ESD. And then I've already spoken to you about this particular patient itself, where you've got LSTG homogeneous type itself, and this patient has got very scarred area that we saw originally, and then we have to resect these by ESD because very difficult to get piecemeal EMR on these patients itself. It's this patient post-radiotherapy, and they had a big LSTG homogeneous type, very difficult to resect, and therefore we have to resect these lesions en bloc with ESD. An LSTG homogeneous type, in terms of our algorithm, we've talked to you about doing piecemeal EMR for these patients, but there is a price to pay in terms of recurrence. There are challenges in our practice, and that is that the people get a lot of fibrosis because we have patients that have a lot of biopsy and heavy manipulation prior to referral. Lesions are big, and therefore, once you do a lot of these lesions, and if you are in your practice treating a lot of patients with EMR, you're going to have to deal with your recurrence. So actually now, for the lesions that we used to treat by piecemeal EMR before, we're having to deal with our recurrence itself. In our practice, about half of our patients have had attempted resection or heavy manipulation, which we count as either snare resection or greater than 6 biopsies prior to referral. So we need to educate really about biopsy in order to further training in Western practice, because otherwise we're going to have a lot of problems dealing with our recurrent lesions. This is just an example, and just try and follow me on this. This is a polyp that we had in our practice. It was biopsied, and the biopsy suggested that this was actually low-grade dysplasia. That's where the low-grade dysplasia biopsy is. That's where you can see it on the slide of low-grade dysplasia. This is where the cancer is on en bloc resection. So biopsied multiple times, but until you resect this, you're not really going to see the invasive cancer there. Multiple repeat biopsies prior to resection showed low-grade dysplasia. This is another lesion as biopsied 14 times prior to referral, tubuloadenoma, low-grade dysplasia. When we resect this lesion en bloc, this is what we see. We see the invasive cancer just below the muscularis mucosae. You're never going to reach that with your biopsies itself. So, in my opinion, the two considerations we need to have in order to avoid unnecessary future problems are really thinking about avoiding unnecessary biopsy and really think twice about the patient and that particular polyp characteristics before embarking on piecemeal EMR. This is just a very, very busy slide, but it just demonstrates, demonstrates some clear messages. This is looking at the degree of manipulation of either failed attempt for previous snare resection or heavy manipulation, which is more than 6 biopsies or less than 6 biopsies prior to endoscopic resection. And if we look at this, endoscopists are more likely to have a go before referral for lesions that are easily accessible, which are usually the ones that are in the rectum and they are flat. And these are the lesions that you all want to train on for doing ESD without having biopsy itself. So we must really think about, educating endoscopists about this. We know that if you have heavy biopsy, heavy manipulation, that will increase complications and reduce the en bloc resection rate and increase recurrence. We know that there are many other factors that would also increase those complications, but certainly heavy manipulation is one of them. And one of the interesting aspects itself is that if you look at the value of the biopsy compared to that of the diagnostic value of multimodal endoscopic assessment with magnification and careful assessment, it's much better just looking at it carefully than taking a biopsy itself. So I think we need to really think about biopsies very carefully. And the other aspect is what we alluded to earlier was about piecemeal EMR. Think about the surveillance that you would need to do on these patients before embarking on this, and think about also what the actual visits the hospital would need to clear this patient of their polyp to deal with their recurrence. But if we look at the risk factors, certainly for both early and late adenoma resection, a recurrence, for patients that have had piecemeal EMR, we will see that obviously piecemeal resection is certainly an independent risk factor for patients having residual adenoma very, very late as well, as are obviously other things, including size of lesions greater than 60 millimeters. So what about the outcomes now, looking at ESD? We've talked about indications, we've talked about the algorithm that we would use, outcomes following ESD. Well, actually, if you look at the outcomes itself, I'm just going to state this. You've got this in your pack. Is obviously the literature suggests that the intraprocedural perforation is between 2 and 6%, with a very low risk of delayed perforation. But certainly the risk factors for this are if you're going to have increased fibrosis and very large lesions that require a long procedure. Delayed bleeding is not some of a problem in our practice, but it's been quoted up to 8%. And you need to be careful with patients that have got a lot of arterial points during the dissection itself, or rectal or cecal lesions, and also patients that have malignancy and they're on antiplatelet or anticoagulant treatment. What about post-ESD coagulation syndrome, where they have pain and fever? In the literature, up to 15% of patients, and we see this certainly more in patients that have a long procedure time and large lesions, particularly in the right colon, if you particularly use too much monopolar diathermy. And we've moved now to pretty much exclusively using bipolar diathermy in terms of hemostat for patients that need coagulation during and after ESD. Just a few words really on pathology before we finish up. And really, you need to collaborate with your pathologists in order to give them a good specimen and identify the areas of submucosal invasion carefully, and then do 2 millimeter cut-ups on the exact site so that you can identify the area of invasion. And this will take some collaboration, similar to the Japanese protocol, and we've been working collaboratively with our pathologists to do just that. So just to finish on, is just to describe just the next few minutes on just some of the technical aspects. I'm just going to go through some of this. Have we got time, Gloria? Am I taking too long, or is this good?
Let's say, I believe it's absolutely fine. And even in the previous call, we noticed that we needed the entire hour. So
okay, fine. Okay, so if people start shouting at me, then I'll stop there. So please feel free to scream out. Okay, so some of the technical aspects I wanted to just discuss and I think are quite interesting. So these have been taken primarily from our Japanese experts, and actually there's an excellent paper which I've referenced in this pack that goes into the technical details of this. But some of the aspects that we need to think about is using gravity and using our inflation and deflation in order to have as much as a horizontal direction of travel during ESD rather than a tangential travel. So a lot of the movement of patients that we do and the deflation that we use really goes to avoid this tangential direction itself. Many of you have come across Yamamoto's pocket creation method, and this is really where you would actually make an incision on the anal side of the lesion here, and then you would actually tunnel in to create a pocket in a butterfly fashion all the way across until you've dissected underneath the whole of the lesion. And then once you've done that, then you would finish your mucosal incision on one side and the other side. And that is a pocket creation method of ESD that we sometimes use. I tend to teach a lot with submucosal tunneling, and this is where you make an incision on the anal side and tunnel through the central part of the lesion. If it's a very large lesion, you can tunnel in two different types, one tunnel on one side, second tunnel on the other side, and then join the two up, and then finish your incisions first by breaking through on the oral side underneath completely, and then finishing one side and the other side, taking gravity into consideration and using turning of the patient to facilitate dissection. So I think that traction and that gravity is extremely important. But when we do use traction, there are certain things that we can also give some tips on. And one of the things that we must think about is, although it's very attractive to use traction like this, as in this diagram here, and see where we use traction onto a clip on the other side, then as you dissect, remember that you would lose that traction. Therefore, you would need to apply multiple clips onto the nylon to recreate that tension. And if, on the other hand, if you use traction up onto the anal side, as you dissect, remember this traction is going to get accentuated and you'll create this sort of tent to facilitate your dissection. So using the traction and gravity can also facilitate resection itself. What about closure? Well, you can do lots of different things regarding closure. You can also do lateral incisions and then closure to relax that, and that's shown here, which is fairly straightforward. I tend to use, for large lesions, I tend to use closure as a clip loop, where you apply a clip onto the anal side with a loop that we've pre-made. I just tie a dental floss, or I tie actually a small suture, a vicryl suture or a proline suture onto this, where then we would then use this to clip much further away on the anal side and then zip that closed with additional clips. And that's what we call a closure clip loop technique. Or you can use a clip line traction as well, either directly, where you would use a clip and a line, which can then be pulled together with traction to bring the two opposing edges together. So lots of different ways to help with traction itself. And obviously you can use endoscopic suturing to close this endoscopically if you have the facilities and expertise to do that. I think prerequisites for training, we've all talked about in our practice. This is what we used to do. Obviously patients would need to be able to be treated by conventional EMR by the endoscopist, and they must assist in greater than 20 cases before we take them on. And there's some evidence of having, what it requires to be proficient. And I think the data from the Japanese is 20 to 30 cases of colorectal ESD under supervision to come over your learning curve. But in order to get high R0 resection rates and low complications, 80 to 100 cases are needed, and they would advocate using much smaller lesions and rectal cases initially. But we know from the European data, and this is European data, that as you get more experienced, your procedural time will reduce and your en-bloc resection rate will increase. So what we've been doing really in our practice is initially doing just as a mentorship program initially of observation and assistant in 20 cases, combined with live and animal workshops, and then supervisor resection for a further 10 cases. And many of you, and some of you have been involved in this, have been involved with the ESG statement regarding ESD training in Europe. And this is more of a formal overview as a position statement that we provided recently. And really what that said was that initially you need to have a certain amount of preparation for ESD training that requires some knowledge and attending meetings, and live conferences, etc., and being familiar with the devices and electrosurgery. And then you have initial animal training itself, which will both be on the platform and also live. And then starting with human experience in the rectum, particularly with supervision of more than 10 cases, and then having at least 8 cases or so without perforation and R0 resection before embarking on independent practice, with regular audit and a minimum of 25 cases a year for having high en bloc resection rate with low complications. So what we do we actually assign in terms of training, to the endoscopist that's training. This is one particular endoscopist that did training for their logbook, and what we say at the start of the lesion, you should either perform part of it or you're expected to complete it. And then we check to see whether they're able to do that. And in the 22 cases that this particular trainee did, we said 13 you should perform part of it because we felt it was difficult, and they fulfilled that. And 9 of them we felt they should complete, and they did complete it with good R0 resection rate, no perforation, including large lesions. So actually, we can provide training for patients for patients safely, and endoscopists who have gone through the program itself. Now, you're extremely fortunate because we have a formal training program, and this is what the basics really we've tried to incorporate many of these previous different recommendations and guidance from the societies itself. So, in summaries, ladies and gentlemen, thank you for your patience and listening in. I think ESD certainly is here to stay, and it's increasing its presence now in tertiary referral centres because we are improving with education, but we still need to work harder regarding educating our endoscopists regarding biopsy and attempted resection. And diagnosis really is the key for appropriate decision making regarding EMR or ESD. And if you ever visit King's, this is Denmark Hill, endoscopy is in the basement down here. My offices are up there somewhere. You're most welcome to join. And I hope once the lockdown is over that we could all meet in person. Thank you very much.